Welcome to the Egg Whisperer Show. I'm delighted to have Dr. Kerin Orbuch today talking about living with endometriosis, what you need to know about healing and hope. Did you know that 1 in 10 women suffer from endometriosis? Yet it often takes years to get an accurate diagnosis. Endometriosis isn't just about pain. It's an inflammatory disease that can impact every aspect of life, including fertility. Today, we're diving into this important topic with one of the world's leading experts. Hi, everyone. I'm Dr. Amy, and I'm thrilled to have a very special guest joining me today, Dr. Kerin Orbuch. Dr. Kerin Orbuch is the founder of IrisWings Sanctuary for Endometriosis Surgery and Wellness in Los Angeles and the author of Beating Endo: How to Reclaim Your Life from Endometriosis. She's one of the country's leading experts in laparoscopic and robotic gynecologic surgery, with a practice devoted exclusively to advanced endometriosis care. Dr. Kerin Orbuch's whole body approach combines surgical excellence with integrative medicine, and we had the honor of working together on the powerful documentary Below the Belt, which sheds light on the challenges faced by those living with endometriosis. Today, we're diving into the tools, treatments, and hope she brings to her patients. Let's get started. Welcome, Dr. Kerin Orbuch.
Thank you so much for having me. I'm honored.
So I just want to start off with endometriosis. As we all know, it can have a profound impact on fertility. What do patients who are navigating difficulty trying to conceive need to know about endometriosis?
I think, first of all, that you're not alone. It's a really common disease that affects, as you said, 1 in 10 or 200 million who are assigned female at birth worldwide. And understanding the etiology of the infertility issues, I think, really does help achieve fertility.
Why do you think so many fertility doctors don't recognize the impact that endometriosis has on a woman's fertility?
Such a great question. I think the concept of a fertility doctor feeling that they can bypass every stumbling block that's not allowing the patient to get pregnant, but endometriosis and also endo was not taught properly in medical school. Certainly for me, not taught properly in my residency. It was only until I got to my fellowship where I understood the magnitude of it. And then after my fellowship, where the awareness that it's an inflammatory disorder, like autoimmune-like disorder. And so I think because the foundational elements are not known to a lot of fertility doctors, they have the concept that they can bypass the endometriosis.
Yeah, you're right. They say things like, well, IVF bypasses it and it'll fix it. And women get pregnant all the time who have endometriosis. Or they'll say something that I think is a little tone deaf. They say getting pregnant will treat it. And that's not fair to someone who's struggling to conceive.
Correct.
What do you think are the biggest obstacles to earlier diagnosis of endometriosis? Why does it take so many years?
I think it's the training for the general OBGYNs, the lack of training or the misinformation. What I always tell my patients is I learned more in my first week of fellowship than I learned in 4 years of OBGYN training plus 4 years of residency. So in 8 years, I learned less than my first week of fellowship. So it's no fault to those general OBGYNs or the pediatricians if it's a teenager complaining about pelvic pain or painful periods. It's no fault to the gastroenterologist either if the patient's presenting with a whole host of gut issues. The misinformation that it's a whole body systemic disorder, that's just missing in training. And I think doctors in general would become physicians because we truly want to help, but the whole training needs to be revamped.
Yeah. And then as a patient, what can patients do along with their healthcare providers to improve this timeline, even as early as the teen years?
I think knowing your disease, no matter what you're suffering from, know it better than your physicians. And that's honestly what compelled me to write this book. I remember I was down in Soho when I had a practice in New York, and I had this beautiful window overlooking the corner of Spring and Sullivan. It was just beautiful. And every time I was sitting across a patient, they were telling me their 10, 20, 30-year journey to get diagnosed. And I always have a tissue box right next to them. They're tearing. I'm not a violent human. I'm actually pretty chill, but I wanted to take my fist and punch it through that window Like, why is it taking so long? So I created my book, Beating Endo, How to Reclaim Your Life from Endometriosis, almost like a guidebook. So whether someone was in Iowa, in the Midwest, the East Coast, no matter where they were, they could take this book to their primary care doctor and use it as a reference, because we don't have a reference. Even amongst our American College of OBGYN, there's so much misinformation. I just think knowing your disease better than the doctor. Well, I mean, I hope that isn't when they come see me, but better than the
Right.
generalist who's taking care of you is so absolutely important.
Right. And just like you said, the doctors go into medicine because they want to help people. And sometimes when the patient presents with endometriosis symptoms, the generalist will be the one to do surgery on them. And sometimes that's not a very good idea. And you're one of few specialists trained in advanced laparoscopic and robotic excision surgery. Not few, but there are other MIG surgeons like you. But do you feel like it's the best option for treating endometriosis to do surgery compared to other approaches?
So that's a complex question. So I'll break it down. When I have a patient come to me for a consult, it's an hour and a half or 2 hours delving into when did it begin, the chronicity. And typically, in my experience, there's multiple pain generators that are involved that happen because of the longstanding endo. So usually there's like tight muscles from clenching and squeezing in pain, or being constipated and straining. Sometimes there's concomitant painful bladder syndrome or interstitial cystitis. Sometimes patients have like an upregulated central nervous system called central sensitization. And then I have to take into account the patient's age, what their fertility plans are, when they're considering having a child. All of those go together in terms of creating a plan. But typically in my practice, I always try to do a mind, body, east meets west approach. So like and I forgot to mention gut stuff. I'm always looking at dysbiosis, both in the small and the large intestine, or leaky gut, to use like an Instagram term. So I do believe that all of the tuning up does help fertility, because I think if we improve the gut, we improve the gut brain connection. If we improve the gut, we decrease the inflammation. We decrease the kind of sympathetic overdrive, or how hard our adrenals are working. So I usually employ get patients in to get tested for SIBO, get them involved with an integrative nutritionist, get them into pelvic floor PT, get them into meditation, mindfulness, get imaging if needed. Parenthetically, we don't see endo on imaging typically unless there's an endometrioma or a cyst of endometriosis confined within the ovary. And then if someone wants to book a surgery, I have no problem booking the surgery. And it depends again on their age, how long they've been, like what they've been doing. But I always start integrative, then do a really good surgery. Excision of endometriosis is the key. And then continue those, like the PT, all of those other things. What I want to talk about, though, from a surgical perspective, generalists don't know what endo looks like. And I was a generalist who came out of residency from an amazing program in New York City. And I only knew 2 appearances of endometriosis, a chocolate cyst and a powder burn lesion. And in my fellowship, again, in that awe-inspiring first week, I learned that endo can be blue, it can be yellow, it can be clear in teenagers, it can be red, it can be like a mess of adhesions. It could be, there's so many different appearances. And if you're relying on a generalist to diagnose your endometriosis and then B, treat it, they're going to miss so many areas of endometriosis. And then a generalist is trained to burn or ablate or cauterize an implant of endometriosis. The reason that that's the wrong treatment is that within those endo implants, and this can relate to fertility, this can relate to systemic or whole body inflammation, those implants of endometriosis are pro-inflammatory. So they're releasing cytokines or inflammatory cascades that are going to the gut, causing dysbiosis. They're going to the endocrine system, increasing the likelihood of autoimmune diseases, Hashimoto's being the most common, going to the whole body, putting us in like this sympathetic overdrive. So if we're going to burn the implant, that means we're getting rid of the tip of the iceberg. We're leaving that whole inflammatory implant behind to keep wreaking havoc on the whole body. And when we think about it from a fertility perspective, the inflammation is what either doesn't let, I mean, this is in my opinion as a surgeon, I'm sure maybe your opinion is different because you're fertility trained, either doesn't let the egg get to the tube or doesn't let the sperm get to the egg, or if in fact they do meet, doesn't allow for proper implantation. So generalists don't know the symptoms of the disease, which I'd like to speak about too. They don't know how it looks, and then they don't know how to do the proper treatment. So long answer to, you want to find an excision specialist who all I do is endo. I don't do pelvic floor reconstruction. I don't do anything else MIGS related. I just do endo.
Yeah. And that's such an important point. You mentioned that you sit with your patients and you talk to them for an hour to an hour and a half, diving deep into the chronicity, their symptoms, and patients don't get that with their generalist. And the generalist isn't as well trained as someone who has done extra training in minimally invasive gynecologic surgery. And you mentioned symptoms. I would love for you to share, what are some of the most common symptoms that you see in your patients?
Yeah, absolutely. So gut issues. So endo is misthought of as a period disease or a menstrual disorder. And what I see primarily are gut issues, typically constipation or diarrhea or alternating constipation, diarrhea, being diagnosed with irritable bowel syndrome, painful bowel movements, often going to the gastroenterologist, having a whole workup, and ultimately being sent home and being told to take Miralax. There's nothing wrong with you, right? So, and often even gut issues preceding their periods, because we know that people are born with endometriosis. There's a genetic component, and these inflammatory implants are patients are born with it. So like gut issues, she could never have a bowel movement, or I took her to the pediatrician, she was always constipated, or she had tummy aches. So that gut issues are primarily what I see. And then systemically, fatigue and exhaustion from a gynecological perspective, either painful periods, painful ovulation, which would be mid-cycle, pain any time of the month. Someone could have perfectly normal periods, but still be in pain. And parenthetically, if someone's on the pill from high school age to prevent pregnancy, they may not have bad period pain because of the medical management to prevent pregnancy. Painful sex, it can be entry, deep penetration, and some have a lot of very heavy bleeding or clots. Others have urological issues like, I feel like I have a urinary tract infection. I got to pee all the time, frequency, urgency, in the absence of an infection on culture. And then infertility. I think what I see is about 30 or 40% of unexplained fertility, correct me as the fertility doctor, is what I see as a cause of endometriosis.
Yeah, you're spot on. I couldn't agree more. And then what happens, for example, when someone goes through menopause? Should they expect the endo symptoms to go away? Because oftentimes patients are told, just wait until menopause, tough it out until then, and everything's going to get better.
So there's so many myths to endo. That is one of them, because those implants of endometriosis, which are pro-inflammatory, they're setting forth this cascade of inflammation. They're still there. And they're also anatomically distorting. I mean, endo has been found in just about every organ in the body. But if we just think about the abdominal pelvic cavity, the implants of endo are starting to pull the uterus, the ovaries, to the right or the left or to the back. That then pulls on the pelvic floor muscles and the fascia that affects our gait. I mean, you could have neck, shoulder pain, foot pain, just from a disease in our pelvis. So absolutely, that is a huge myth. Pregnancy is a myth as curing endometriosis. Removing a uterus or a hysterectomy is a myth. There's so many myths that generalists are spewing, not because they're bad humans. They're wonderful people. It's just, they're just passing along misinformation.
Yeah, they're passing on what their professors taught them. Yeah. And they're just spreading those endometriosis myths. I have one question about endo, and it's related to ovarian cancer. What do women who have endometriosis need to know about any potential risk for ovarian cancer in the future?
Yeah, so largely we know it's rare. And I'm going to just kind of not answer the question first, just to so the audience can take a pause and a deep breath. I have seen one case in over 2 decades. Now, obviously there's patients lost to follow-up, people move, I may be missing patients, but we know in particular it's the endometriomas. Those are cysts of endometriosis within the ovary. Those have a higher likelihood of ovarian cancer. And it's also, there was a paper that came out within the last year, if someone has more scarring, more long-standing endometriosis. So this is why whenever I have someone with an endometrioma, we don't sit on it for a long time. We want to make sure it's okay. And then I continue to follow them long term. And if someone has completed childbearing, a risk reducing strategy to decrease ovarian cancer is removing the fallopian tubes, because we do know that some ovarian cancer does originate from the fallopian tube. So if someone's out there, completed childbearing, they're having a hysterectomy. Hysterectomy is not the treatment for endometriosis because by definition, endo is external to the uterus. Hysterectomy would only be for treatment of endo confined to the muscle of the uterus, known as adeno. But if you're having that, then also remove the tubes.
How should a patient advocate for themselves when it comes to monitoring their endometriosis over time? Is it an annual pelvic ultrasound? What should they ask their doctors for?
Oh, this is such a good question because we don't have that in a model these days. We haven't studied if you do imaging every three months, because ovarian cancer, first of all, the symptoms, let's just talk about how rare ovarian cancer is, just to put it in perspective. Breast cancer is uber common. 1 in 8 women develop breast cancer. Ovarian cancer is 1 in 70. The average age is 63. Those with endometriosis have a 2 to 3-fold higher likelihood of having endometriosis, but we're still nowhere near the breast cancer. So just to, make people feel a little bit better. But the symptoms of ovarian cancer are very nonspecific. It's like bloating, constipation, urinary frequency. I mean, these are things that I have every day. I think most people have those things, but if you're noticing a difference, those are signs. So it's really hard because a lot of things in medicine are, how can we be cost effective? I don't want to waste resources in this world, but I also want to save my patient's life. So, a lot of things in medicine are, how much money are we going to spend per patient to decrease mortality or death? And it's how many false negatives are we going to have, which is going to create an intervention that all costs money. So I look at it a little differently. So I usually have patients go for imaging at least, let's say, and it depends on their age and it depends on how extensive their endo was. And sometimes we follow some tumor markers at the same time. And it depends on family history and it depends if they're BRCA 1 and 2. So there's no absolute also.
Yeah.
Do they have other genetic syndromes that can involve the ovaries as well? It's a tough one. I'd say we'd have to individualize treatment for that. Yeah.
Right. And I love your book, Beating Endo. I learned so much from it as well. And it's so complete. And in your book, you aim to empower women with knowledge about the disease. What are some of the most important tools or insights from the book that you hope every endometriosis patient walks away with?
I think to know that you're not alone and there is help out there, and to believe your pain. That is so powerful. Most patients come into my office and they're dissociated from their own bodies to the point where I'm like, well, where is your pain? No, I don't know. Well, I mean, is it on the left side, the right side? I don't know. The reason they don't know is because they've been told since they were a little kid or when they started their menses or at some point in their life, they've gone to doctor after doctor. I mean, in the US, we know that patients see on average of 8 physicians over a course of a decade until they're diagnosed. Forget about then how many surgeries do they have done before they get to a proper excision surgeon. But I can speak as a we because I have endo, my daughters have endo. We're so defeated because we're told time and time again, you look normal, you look great, or you don't look sick because it's an invisible disease. Your ultrasound is normal. There's nothing wrong with you. So trust your knowing and know your knowing. Like that is probably my number one thing that I tell patients, and know that there is help out there.
So if someone is listening to this and they say to themselves, I really want to reach out and become your patient, where can they find you?
Yeah, we would love to see you at IrisWings Sanctuary for Endometriosis Surgery and Wellness. We're located in Los Angeles, but we see patients throughout the country, actually throughout the world, virtually. And then people love flying into California for surgeries. You can check us out at lagyndr.com, like lagyndoctor.com. You can find us at IrisWings, IrisWings.com, on Instagram at Dr. Iris Kerin Orbuch, IrisKerin-Orbuch. And my number is 310-651-7333.
Awesome. And what about your book? Where's the best place for people to buy your book if they would like to buy it for themselves and buy it for their doctors?
Yeah, absolutely. On Amazon, just Beating Endo, How to Reclaim Your Life for Endometriosis. I think the one thing about the book is that everyone says it validates their pain, that they tear and cry, because a lot of the case studies are like, I was that patient, that was me. And it empowers them to then seek answers, not necessarily treatments, but more diagnosis, potentially earlier diagnosis. But one thing that I've been really seeing over the last decade that has helped my patients so much is really addressing the gut, because the gut is where like 90 or 95% of our serotonin comes from. And endo's like autoimmune, like it turns on all of these autoimmune diseases. So I really do feel that treating the gut and treating the endo is like a game changer for endo patients. And it's not treating the gut, seeing a gastroenterologist. It's treating the gut, seeing a gastroenterologist and an integrative nutritionist. Not a nutritionist, no offense, associated with a hospital who knows diabetes patients. The food pyramid does not work for endo patients. I don't think it works for anybody, but like you need someone who understands autoimmune diseases, anti-inflammatory eating. So I do believe like lifestyle is not going to remove endo, but it does decrease the inflammatory state of our bodies.
Yeah, such a great point. I refer my patients to a functional GI doctor. He's a gastroenterologist, and he basically just focuses on exactly what you talked about, SIBO, nutrition, and he's been a great resource. And, you know, just like you want to save lives, like patients really feel like their life has changed, and it's like they get to reclaim their life after the care that they receive from you.
Yeah, hence the title of my book. I mean, I sat with the title for so long until it really came to me that I want patients to beat endo and reclaim their lives.
Thank you for such an insightful conversation today. Thank you for taking time out of your busy schedule to come talk to us about endometriosis and your book.
My absolute pleasure. Thanks for having me.
Thank you so much for listening and making the Egg Whisperer Show a part of your weekly routine. To find show notes and a full transcript for this episode, visit dramy.org and look under the blog tab. While you're there, you can find a link for the Egg Whisperer newsletter, which keeps you in the know about fertility news. You can also find Dr. Amy and the Egg Whisperer Show on YouTube, Instagram, or Facebook. If you'd like to learn even more, Dr. Amy offers classes at the Egg Whisperer School, eggwhispererschool.com, or you can request a consultation on dramy.org. Thank you so much for tuning in and for sharing the Egg Whisperer Show with others. Keep sparkling and have a great day.